Arthroscopic shoulder stabilization, or arthroscopic Bankart repair, is a minimally invasive surgical procedure that I use to repair ligaments and the labrum of an unstable shoulder that has been damaged from a previous shoulder dislocation. Using small arthroscopic incisions, I can repair the ligaments and labrum of the shoulder joint and restore stability.
Indications for arthroscopic shoulder stabilization include patients who've experienced a traumatic shoulder instability episode or dislocation and are at high risk for recurrence. These include patients of younger age and high physical demand level, and those who have already demonstrated recurrent dislocations. Before surgery, we do need to have an adequate shoulder range of motion before we proceed. The pertinent anatomy includes the humeral head and the ball of the shoulder joint and the glenoid, the socket. And with the dislocation, the ball exits the shoulder socket and creates an injury to the ligaments and capsule where they attach to the socket typically. We call that a Bankart lesion. Unfortunately, this lesion does not heal and requires surgical repair to restore stability to the shoulder joint. The typical history is a young, active patient who traumatically injures their shoulder, such as a football player trying to make an arm tackle, who will sustain a dislocation of their shoulder. Subsequently, if without treatment though, they continue to have recurrent dislocations. Initial examination reveals pain and decreased range of motion. However, as time subsides, the shoulder does usually regain its full range of motion, and the patient is left with just particularly pain and mostly apprehension with the arm, we call it externally rotated and abducted, up above their head, as that reproduces the position of dislocation and therefore also the symptoms of instability. X-rays are performed to look for any signs of fracture to the ball of the humerus or the socket, the glenoid. MRI reveals the pathology, in particular the separation or tear, or Bankart tear, where the labrum is torn from the anterior front part of the socket, along with the capsule and ligaments attached to it, allowing instability. Additionally, on the posterior or back side of the humeral head, we see an indentation called Hill-Sachs lesion or fracture, where the actual posterior aspect or backside aspect of the humeral head is indented on the front of the glenoid during the dislocation episode. The goals of surgery are to restore the normal anatomy contributing to the stability of the shoulder joint. That includes the bone, labrum, and ligaments. Another goal is to decrease the risk for recurrent instability as well as minimize trauma or injury to the surrounding tissue as we perform the surgery. Viewing from the back or posterior side of the shoulder joint with the arthroscope, we're looking towards the front where this capsular labral tissue has been torn off the front of the glenoid socket. At this time, we're just elevating and preparing the bony glenoid in preparation for reattaching the capsule and ligaments. A suture shuttling device is inserted, and this allows us to grasp this capsular labral tissue and pass a temporary shuttling suture through the capsule and labrum. Once that's retrieved, we drill and insert an arthroscopic absorbable anchor into the bony edge of the socket that allows us to attach sutures to the socket for the repair. We then grasp the shuttling suture along with one of the sutures from the anchor and exchange that to allow our suture from the anchor to be passed through the capsule and labral tissue. The ends are then retrieved and sorted and then tied arthroscopically to repair the capsule and labral tissue back to the socket, reestablishing the proper tension as well as creating a stabilizing bumper effect of the labral tissue along the socket as there used to be before the injury. And we repeat these steps working along the tear site until it's completely repaired along the socket. This arthroscopic approach, we're able to address all these capsular labral tissues without violating or damaging any of the other surrounding muscles, including the rotator cuff. Typically, when this procedure is done through an open incision, the rotator cuff has to be transected and then re-repaired in order to gain access to the joint as we have done here arthroscopically. This is a significant advantage for recovery for the patient. Rehabilitation is begun right after surgery with some home exercises, and people get into physical therapy 2 to 3 days after surgery for up to about 4 months. There's a sling for the first 6 weeks. People can't shower for the first 3 days after surgery. They eventually resume normal activity when the sling is discontinued, including driving at about 6 weeks after surgery. But return to full activities, including sports and other strenuous or contact activities, doesn't begin until 4 to 6 months after surgery, when healing is complete. If you have any questions or concerns, don't hesitate to contact me, Stephen Shuddick, at 630-794-8668 or at my email account. Thank you.